Good evening, everybody. Welcome to this webinar on change management and general practice as we move into level 2. So welcome to this webinar and welcome to level 2. And so far things are looking okay. It's interesting, we've been on a heck of a roller coaster ride over the last 7 weeks. About 4 weeks ago, we were talking about how we respond, recover and rebuild in the challenge to COVID. And tonight we're up to the rebuild stage as to how we take some of these learnings. I was listening to a budget presentation from Grant Robertson today, and guess what words he used in presenting the latest Labor budget was respond, recover and rebuild. So everybody's in that mindset currently. So COVID has presented a lot of challenges, but it's also offered and presented us with opportunities as well. And there are a number of changes that we have made to our practices under the veil of safety that everybody is saying we don't want to go back now. We want to adopt these changes, keep them locked in. And patient expectation will have that of us as well. I don't think patients are going to tolerate sitting in waiting rooms full of people spreading germs in the way that we have in the past. So there are some other words I want to use, and that is, how do we reconfigure, re-engineer and reimagine the future for general practice for both ourselves and for our patients? So in doing that reimagination, we have an expert panel that we have assembled here tonight. And so I'd like to welcome Nicky Hart from Feilding Health Centre, Lance Norman, Equity Lead from ProCare, Mabli Jones from Te Compass Health, Healthcare Home Lead, and also Jess White from Te Awakairangi, who are going to talk us through. Now, we're not saying we've got all the answers right. This is to open debate, and we welcome your questions and debate on this. So shortly, we're going to get into their presentations. Just a reminder, your questions we will have at the end of all of the speakers, and there is a question and answer function at the bottom of your screen that you can send your questions along, and we will field those questions, answer them with the chat function as we can, and we'll put other ones to the panel at the end of that as well. I'd like to thank all of our speakers tonight for your input tonight, for everyone attending tonight, and I'd also like to thank the Healthcare Home Collaborative and GPNZ for sponsoring this event, and in particular the hard work of Armajit Maxwell, Scott Emeris and Liz Stockley in putting this together. At this point, I'd like to hand over to Lance Norman to say a karakia.
Kia ora, Jeff. I'll just open a hui with karakia. Tūtama mai I runga, tūtama mai I raro, tūtama mai I roto, tūtama mai I waho. Kia tau ai, tia Maori tū, tia Maori ora, kia katoa, haumi e, hui e, tai ki e. Kia ora, Jeff.
Thanks, Lance. Kia ora. So I'd like to hand over now to our first speaker, Nicky Hart, and she's going to talk to us about how to manage major change in general practice during COVID-19 and Alert Level 2. So Nicky, over to you.
O tēnā tātou katoa, ngā mihi nui, ngā mihi mahana ki a koe, Jeff, mō tō mihi ki a tātou, ki a Lance, tēnā koe, ngā mihi ki a koe mō tō karakia I tēnei pō. Hi everybody, and big thanks to the Healthcare Home Collaborative for hosting this again, this follow-up webinar, and I'm glad to see we didn't put people off last time and that there's some people that wanted to come back and listen to us again. It's, I certainly don't, like to consider myself an expert, but maybe mug enough to come on the screen and share some ideas and, to generate discussions and also give a sense that the struggle is shared, but also the opportunities and the really good things that are happening are shared as well. So that's certainly why I'm here today. I'd also want to just acknowledge the remarkable progress that people have made in terms of in the space of virtual care in a few very, very short weeks. And I've got no doubt that the changes are going to result in a major long-term benefits for patients and for the system as a whole. So for me, that's really exciting and it's reinvigorating. It's a real shame that we've had to do it in the context of a coronavirus, because that's quite taxing and challenging, but I think there'll be some really good things that will come from it. I think it's a big challenge now, though. I think we're all saying we'll take these things forward, but sometimes when we lose the, I think as we move down the alert levels and we are not forced into a virtual first environment, it's going to be quite easy to fall back to pre-COVID operating, and there'll be some things some challenges, and unless we plan now, we're likely to just go back to what we were doing before. And it's not because we don't want to change, it's just human nature. Sometimes when things get a bit hard, we just, revert back to things. So virtual care, I think, is worth holding on to. It's a phone and video consultations are a wonderful service that we can provide for our patients, and there's a lot of long-term benefits that will come if we can just hold on to some of it. I also just wanted to point out before I go on that my expertise are in management, so all of the things that I share need to be considered in the context of your own clinical practices and approaches to quality. So for us here at Feilding Healthcare, we probably, before the COVID crisis, had about 15% virtual care, and we have been dabbling in video consultations over the last 18 months and probably done maybe 50 to 100 video consultations over the last 12 months. Since the COVID crisis, we're probably up to about 85% virtual care. And we think we are going to land as a new business as usual, maybe around 40 to 50%, but we're not really sure. It's a little bit unknown. But I think the assumption is, certainly my assumption at the moment, is that the 85% is not sustainable, and we're not always going to be in a situation where it's easy to say to patients, virtual first, phone consultation before anything. So we need to consider what the new arrangement's going to look like, the 50-50 arrangement. So the first, I guess I'll talk about video consultations first, because we've tried a whole lot of things around video consultations, and actually as a manager and been in primary care for a long time, I have found video consultations to be one of the more difficult services to implement as business as usual, and that's because there's a lot that can go wrong. There's a lot technically that can go wrong, and there's a lot in terms of the workflow that can go wrong. So we've gone from 12 months ago, we thought, well, maybe the nurses could book the video consultations through their triage, and that didn't work particularly well for a whole lot of reasons. Then we went to, oh, well, should just be GPs that are booking virtual consultations. So they're the only ones that will know whether it's appropriate for patients, and that hasn't worked so well. There's been a whole range of things that we've tried, and next week we are fully implementing our new business as usual approach, which is a script at the front desk where all patients are triage. So that, are you sick today? If you're sick today, you get a telephone triage from a GP. And if it's routine, everybody's going to be offered a video, a phone, or an in-person consultation if they think that's appropriate. So the patients will get the choice. In addition, GPs can choose to turn a usual appointment into a video consultation, and patients can also book their own video consultation through, we use Manage My Health as a platform. So we're going to try that as our standard approach, and we've tested it a bit over the last 2 or 3 weeks, and we think that's going to work pretty well. And the basis of that is we think patients should have the choice going forward. I think something that will happen is that when video gets too hard, people will revert to telephone, but what we know from feedback from the clinicians is that there's a really good place for video, and that a lot of patients like it. It's much easier to convey, warmth and empathy and all that sort of stuff over a video. So we don't want all of those virtual consults to revert back. That said, there's lots of challenges. We probably have about a 30% failure rate on our videos. The audio visual doesn't work for the patients, and there's a whole lot of stuff that can go wrong. So we're committed to keeping at that and offering a video consult for people that need it. The other one I wanted to talk about, which in some ways has been even more difficult, is how do we implement phone consultations as a standard service? And This is really easy when everybody gets a phone consult and everybody gets a call back. The things that have come up for us is what is the difference between a GP triage call and a phone consultation, because some people say, well, all our GP triage are just phone consults, so why don't we just have all GP triage? And our practices make quite a clear distinction between that. It's not always that clear, but the way it works for us is that we have opted for 7-minute telephone triage in the morning, so at those peak times when everybody wants the same day, brings in for their same day request for service, telephone triage, 7 minutes. Sometimes that does turn into a service, so a person gets a prescription or it has a longer phone call, and that is then invoiced and treated as a phone consultation. Most of the time it's a triage, and some of the time they get to come in, but generally it's a pretty quick conversation. In the appointment books, beyond that, we have 10-minute phone consultation slots. So then the next question is, well, how do patients book those? Because if they're using our patient portal, they don't know the difference, but you can't tell on the patient portal the difference between a phone consultation and an in-person consultation. So where our practice has got to is we are offering routine phone consultations through our patient services team, so they can't book online. We've just found that too difficult to, you can't put messages up saying, well, the 10-minute consultations you see are phone ones and the 15 minutes are not, and it's just way too complicated. So we're hoping the PMS vendors are going to get smart about that and help us to create ways that we can determine from a patient-facing point of view the difference between a phone and a video. The other little tip, might be getting into too much detail, but one of the things that's been a bit of a stress for us around how do we have phone consultations routinely is all of our systems, appointment reminders are built on face-to-face. So if you book an appointment with our practice, you'll get a text message saying, you've got an appointment tomorrow with Dr. Stewart, come in and come into Feilding Healthcare. But if those are phone consultations, then practices are going to end up with a whole lot of people coming in, but they're phone consultations. So we've come up with a few workarounds to that, which is about, so we've created procedures in our appointment books, and we've also found out the little trick of putting star in the comments box, which means that those people won't get an appointment reminder. So I guess the reason I'm telling you this in detail is that there's a lot of, all those things will be barriers for you in your practice to be able to offer these things going forward, but there are solutions at the moment and little tricky workarounds that you can get around all that. So don't let that stop you. And I think on the whole, our appointment books look very different. So we're having triage first thing in the morning, first thing in the afternoon, about 50% on both session routine phone consultations, and then the rest of it will be in-person consultations, and some of those will be acute, so some of those will be routine. So it's kind of where we've landed in our practice. So I think, given I haven't got a long time to go on because I've gone for a long time, but I think the key message I would say at this stage is get practical with your change management and actually think through what you want things to look like once you don't have the ability to say to patients, all of the appointments are virtual first. Your practice might want to do that. You might decide that all of your appointments are virtual first, and that's fine too. But if you don't do that, then what are the workflows going to look like from the point that the patient requests an appointment, whether it be on the portal, et cetera, to the point that they turn up in the practice, and identify all the things that will go wrong, because there's quite a lot that can go wrong. And then so you need to look at your appointment books, your appointment reminders. What are all those systems telling patients about the different types of appointments? Reception staff, what are they saying? How do they know the difference between what they can and can't book? And what are all of these systems communicating to patients? And then the final thing is, how do you market this, to your patients and tell them that they can now get these great services even beyond the COVID situation? At the moment, I see a lot of practices saying we have to do this phone first, and because we're in a COVID crisis. So what's your new message going to be? Is it that we're going back to what we did before, or what's next? Yeah, I think that so there's a lot to this, and and certainly if you've got some ideas around these challenges, please send them in and type them through the webinar, because yeah, I've definitely given this stuff a lot of thought, and there's still quite a lot that will be tricky going forward. So I'm really keen to hear the innovative ideas that people have got. And with that, I will hand back to Jeff.
Great, thanks, Nicky. That's really useful. Interestingly, when we had our directors meeting on Monday, we were coming out with all the same issues that you've raised. So it is the questions that are on people's lips right now. So really timely to have this webinar tonight and share some of that in terms of ideas and anxieties, I suppose, as we go forward. So a lot has changed with COVID, but a lot hasn't changed. Well, one thing that hasn't changed is that equity remains front and centre. And in fact, equity has probably been elevated by this. So we're now going to hear from Lance Norman, who is going to lead a discussion or talk in equity and how we keep it front and centre. Thanks, Lance.
Kia ora, Jeff, and kia ora, Nicky. Thanks for that. So I'm the head of equity and Māori health outcomes for ProCare. I also work at the National Tele Services with the same role, and also work across Fresh Minds New Zealand on the same role. And in a prior life, I used to be a CEO for a Māori public health organisation and helped set up the commissioning agency. So what I've done is in the last 8 weeks on lockdown, I've been just reflecting on some of the things that we could change, because in my opinion, the healthcare system was broken in a few instances. And I thought, how do we have a system, particularly on a virtual platform, that changes our healthcare system going forward? And I'm just reminded of two challenges we have in the healthcare system today. Is some of our workforce is not as culturally competent or as culturally safe as we'd really like them to be. And then at the other level, we've got a lot of our communities who have very, very low health literacy and don't really know how to navigate through the healthcare system. So when you look at what we could do in the virtualization system, in the Māori model of care, there's four key principal components. The first one is whakawhanaungatanga and building relationships with communities. The second component is doing a needs assessment on what I need in my family. The third is actually helping me on my journey to resolve those, and if it's in a medical environment, then it's a nurse or GP-led model. And the fourth is if there were other things in my social background that you could help me with, please navigate me to those positions. So I started thinking, well, actually, in the virtual world, we could do all of those really well. And I started thinking, well, this could actually be a virtual consultation. And I'm ringing up Dr. Jeff for my consultation. But the first pop-up message says, would you like your greeting to be in English, Te Reo Māori, Tongan, Samoan, Fijian, sign language, Mandarin, other languages? And then there was a pre-recorded welcome in my respective language that I chose. So immediately I would feel engaged in this clinical intervention. The second pop-up could be, would you like to open this consultation with some sort of karakia or prayer? And if I chose, yes, I would like a Te Reo Māori prayer, then a pre-recorded kaumatua or kuia from my local marae or iwi would say a karakia that I would feel quite culturally warm and welcomed into this virtual consultation. The next component could be, what are some of the things you'd like me to discuss in this virtual consultation? Is it mental health? Is it cervical screening? Is it about my WINS benefit form? You could have a predetermined list of menu items that I could self-select as the patient dialing into the virtual consultation, so that the clinician would actually have quite a bit of information about what some of the needs I had today. And then as a breakout, say by way of example, I was a Tongan woman dialing in to organise a cervical smear, and it could say, would you like some information about this intervention before you entered into the clinical virtual consultation today? And if I selected yes, it popped up with a Tongan nurse talking to a Tongan woman about it in a culturally appropriate way. It could be done in English, it could be done in Tongan. And then I would have much more informed views of my consultation today. If it was about immunising my baby, it could be a nurse with a mum and her baby talking about what could happen or what will happen in the intervention. So I haven't even entered the clinical environment, and I've had a culturally competent welcome. I've been had a spiritual welcome in a language that I've chosen. I've had a self-assessment that I've chosen, and I've had some health literacy, and that's before I've even talked to you, Jeff. And then I'm on the consultation. Jeff's seen all the interventions that I chose prior, so he's already aware of what I chose. So rather than just talking about maybe one intervention, Jeff can then actually expand on some of the things that he's had visibility that I've clicked on my pathway prior to that. He could then do the consultation as normal, and then he could extend the consultation to say, well, actually, Lance, I'm ringing in from, you're ringing in from your house, and I just noticed there's a couple other family members in your house that haven't been to see me for a while. Is there an opportunity for me also to talk to them? It's highly confidential. We won't share information across consultations, but while I've got you at home, could I also talk to some of the other family members about some of the items that I could help them and support them with? So you've opened it up to a whānau wider sort of consultation. And then through the virtual system, we now know that we can do electronic prescribing. So there might be an option that Dr. Jeff says, hey, Lance, would you like your prescription to be printed out at your local pharmacy, or maybe some organisation that can deliver that to your house because you might have some sort of barrier in picking up your pharmaceuticals. We know that some organisations waive the $5 prescription fee if you order more than 4 prescriptions at a time. So there could be a consolidation process for different whānau members, and it's delivered to my house. So I know I can now do that all virtually because we've changed those rules in the last 8 weeks. And then on the way out, after my consultation, there's 3 things that could occur. One could be, do you have any other concerns in your health and well-being at the moment that we could help you navigate to other organisations? And by way of example, there could be a budgeting button, there could be a domestic violence button, there could be a housing button, there could be an employment issue button. And if I selected that, that would either send my details, my personal details, to that organisation to contact me, or it would notify them for the organisation to contact me directly, with obviously the appropriate confidentiality statements and data sharing protocols. But I've created a pathway to other organisations that will help improve my health and social well-being today. And then the second to last thing could be just the virtual, how was your, what was the satisfaction of your consultation today? You know, when you go through the airport, there's the happy face all the way through to the sad face. You could just click on those buttons. So we're getting real-time satisfaction survey data on a clinic-by-clinic basis, rather than doing an annualized survey, which can be distorted because of the timing, and generally aren't well represented for Māori and Pacific communities. So you could do it in a culturally appropriate way. You know, hey, this is choice, no, this will stink. You know, everyone would understand what that meant. And then that you're gathering that data, and then on the way up, hey, we noticed you started with karakia, we're automatically going to close with karakia. But how I've just described that could be done in any language, any religion. Some of the key messages could be filmed nationally, and we could set up a national data set on how to provide key messages for our communities. Some could be done regionally through the local PHOs, and some could actually be done by general practice. So over time, it becomes a personalised message. Now, all of this data can be saved in the patient portal, so that when I log in as my patient, I can automatically click on the ones I've already saved previously. So I don't have to go through the same process each time. I can just click on the ones that are relevant to me. But equally, the clinician can see the ones that I've clicked on regularly, and I might choose to contact the patient if they frequently are downloading the same sort of key messages, because maybe I could provide some more advice. And then virtually, this could lead into some bigger projects, like rather than pushing out text messages every winter to families to say, come in for your immunisation, you could actually use patient portals to say, whānau, who's interested in a flu vaccination this year? We can book your appointment in, or you can book your appointment in through the patient portal. That could actually help determine the volumes of purchasing your flu vaxes, which then could feed into the DHB purchasing system. So there's huge opportunities around virtualization. You could do group consultations where this could be a diabetes DSME course held for 10 people. It could be pre-recorded with a help desk line. So yeah, so all of these things are possible. And then, I mean, the things we should be doing in the face-to-face process as well, but on a virtual basis, we can actually make it more efficient by doing it, filming it once, and then just sharing across all of our primary care network. So that's probably the key one there, Jeff. You know, add any queries to the chat box. But you know, I'm just encouraging people to think outside of the box, or inside this box, but outside of the normal rock in and come and see me box. And this is a way better way, especially we have when workforce is a limited issue. How do we use our one voice across many people in our communities? Kia ora.
Kia ora, Lance. That's fantastic. And clearly over the last 7 or 8 weeks, you have been doing a lot of thinking. And it's fantastic to hear that we now benefit from all that thinking that you've done. And I know when you presented at National CEOs on Friday, everyone was blown away by what you've imagined. And we look forward to having further discussion about that tonight and in the future. So kia ora, Lance. Yeah. So we'll now move on to Mabli Jones from Te Ora Compass Health, one of the healthcare home support team there. Mabli's going to talk to us about virtual care platforms. So over to you, Mabli.
Thank you. So I think what I've been asked to do is sort of share our experience, which is very similar to the rest of the experience of the country, really, that on March the 23rd, you know, our practices became virtual first providers of care, as Nicky said. 80% of our consultations changed, like everybody, to face-to-face and video. Another thing that happened during that period, which again, you saw this sort of leap forward in terms of change, was we had quite a low uptake of e-prescribing at the time, and we've now moved in that period to about 95% of our practices. I think we have one practice left that's not e-prescribing, but also about 30 practices have picked up the full paperless. So again, that sort of change opportunity came and people jumped at it. We had a big uptake in the use of patient portal during that time, e-communication, and a big, again, adoption of open notes as practices began to communicate with their patients virtually. During this time, we decided to take the opportunity. 2 of the change team were very keen to start a piece of work to record the adoption of new technologies and ways of working with our practices, and they joined the we did sort of 58 virtual meetings with our practices over this sort of 6-week period, and they began to record the results, including a sort of a nice model that they looked at, kind of looking at readiness to change, so sort of adoption and adaptation. And what sort of became clear really was that there was a sort of difference emerging, for us at least, between healthcare home and non-healthcare home practices. So you know, we were sort of thinking, what was that about? And I think for us, when we reflect on it, it was probably because healthcare home practices were used to changing and adapting their service models. Their head was in the change space, so to speak. So their ability to be agile was there. A lot of them already had that required infrastructure in place, so patient portal uptake in large numbers. They'd already done a lot of telephone work with Triage. They'd invested in some of the IMT already, so could offer video consults. 3 of them bought the commercial package of DoxyMe straight off the bat, actually, and many of those invested in additional cameras and laptops. They'd already done the investment in the telephone systems, so they had those call metrics available, and we're used to looking at those. Most of them had already begun the adoption of some form of e-prescribing, so the move to paperless has generally been with the healthcare home practices. And lots of them as well set up virtual huddles and stand-ups to stay in touch, and they used their sort of visual management boards, which quickly then became virtual. So it's not to say that non-healthcare home practices didn't make that leap forward. I think what we noticed in their sort of change piece of work or assessment of readiness or adoption was that the healthcare home practices just moved a wee bit faster. I guess some of the innovations we recorded during this time, really nice little examples from practices completely initiated by them. Virtual year of care planning with the nurses. Several practices went down that route. Once the dust had settled and the nurses' workloads sort of died off a wee bit, several of the nursing teams decided to start doing virtual year of care planning with their patients, sometimes using just telephones, but often using videos. We had several GPs do virtual palliative care, virtual art care, using the risk stratification tool to identify patients who'd not been in touch during this period, high-risk patients, and sort of proactively reaching out to that group for a check-in and or longer appointment. And using the group consultation function of Doxy.me to include other people in the appointment, so factoring in the interpreter, another family member, a social worker in one case, a clinical pharmacist in another, who are all in their own separate bubbles elsewhere in the country or within the Wellington region. And it sort of meant that that 15-minute appointment became a much richer experience for the patients and the care team. Our high needs practices actually really adopted this. Two of the practices that have asylum seeking and refugee contracts realized really quickly that actually they could bring the interpreter into a virtual consult using that function, and it made that consultation so much easier. So I guess where to next for us? We're really keen, like everyone else, I think, to capitalize on the change opportunity that COVID's given us. We're focusing now on really trying to embed the new ways of working and not to lose the ground that we've gained. We are really keen about rapid adoption at scale of the new virtual platforms. And as Nicky said, there are lots of frustrations with those. Some practices have jumped right in and others are really struggling with some of the technicalities. But I tried to myself make an appointment with my GP using my portal this week, and I was offered that menu choice. Do you want your appointment in person, video, or by telephone? And that's great. So practices are really beginning to put that in place. We're quite interested in looking at a need triage tool, which N4, I think, the 4 big PHOs are looking at. I certainly work with that in the UK, and it's a nice virtual tool that allows the patient to fill in a lot of data before the appointment, using some sort of artificial intelligence, and sometimes can actually end up like triage with the patient not needing an appointment at all. So we're really keen to look at that. It's a bit UK based, and I think the aim is to try and to almost buy the software and adapt it for the New Zealand market. But I think that's another innovation we'd quite like to try. We're looking at home monitoring with the DHB locally, which I know other areas are looking at. And the kind of scope and utilisation of the extended virtual clinician. One of our healthcare home practices has just appointed a GP associate who lives in Japan, and is finding themselves out of work because the ski fields are shut and the Chinese students have gone. So, and they needed a GP. He's a New Zealand trained doctor. He's very keen to work. If that way they can offer extended hours, because obviously when he's awake, it works very well for them. And so they've just approached us to say, is that possible? And I've said, yeah, go for it. That'd be a great idea to solve your recruitment challenges. So again, this is a husband and wife team who've been practicing for many, many years, and not sort of almost the kind of innovators you would imagine, but it seems that COVID has really sort of pushed them forward in their thinking. Our considerations, I think, locally are the issue of digital equity. We're keen to push out Doxy.me, but also to look at embedding that into our new provider portal. And we're working with some of the telecom providers around free data. Certainly the high needs practices were reporting that data was often a barrier to access. So looking at free data for patients would be a way forward for us. So we've just commissioned a piece of work with a local provider that we're working with currently on a range of other initiatives to look at enabling that. So a sort of one click for the practice, one click for the patient, that kind of waiting room function, which seems to be really useful. So the patient's waiting and the GP clicks in, and other parties are clicked into that appointment as well. And a kind of pay as you go, so a kind of payment function being embedded into that as well, which I think the commercial version of some of the other systems do have. We are very keen to look at kind of community network development in our patch, and so the readiness to change was a really interesting thing for us, because we saw clusters of practices that were on that higher, rated very highly on their sort of adaptation, adoption and readiness to change further. And actually for us, that's another thing we can start thinking, well, how do we lever that for other developments? Because you've got a hotbed of practices who actually have changed a lot during this period and keen to keep that change going forward. So how do you connect those practices up through community networks? And the other final challenge for us is how we bring the 20% of our practices who are not covered by healthcare home funding along the journey, because you don't want to do from a equity point of view is broaden, widen the gap. So we're working with the DHB actively now to just sort of make sure that those practices are supported to play catch up. And that is not to say that we didn't see some amazing innovations in non-healthcare home practices as well, but they are funded in our network. And I just don't, none of us really want to see that a gap broaden. So that's our experience. I'm sure it's very similar to many others in the country, but I'll happily take any questions when the time comes. Thanks, Jeff.
Mabli, that's really useful, and I think you really emphasise the fact that if you're in that change mindset, it does make a lot of these things easier, and particularly in the context of COVID when we had to do that at pace. Also, that a lot of those components that we needed to change were already there. This is just really giving it a push along, but great to hear some of the new innovations that you're talking about in terms of e-commerce and other platforms. So thanks for that. So we're going to move on to our last speaker now, Jess White, and she's going to talk about how are we going to lock in these changes and continue down this pathway and ensure that we do it in an equitable manner. So Jess, over to you.
Thanks, Jeff, and kia ora koutou. Yeah, I really wanted to share about our change opportunity journey that we've taken with our practices, and you know, just reflecting on what Mabli has presented, our healthcare home practices were the same. You know, they're able to upscale really quickly within that 24-hour period when they had to move to virtual telehealth care. Our practices not in the healthcare home practices, in the healthcare home program, you know, for them, they had to complete these changes really rapidly. And, you know, that meant a lot of support had to be wrapped around them in those early days, you know, just not with just infrastructure, but also training, tools and resources. That, you know, there was a requirement, you know, for new systems and what Nicky's talked about in terms of changing the workflow. This was a significant change for our practices who have been, you know, working their model for years, and you know, the scheduling had changed, payment methods, and just the communication to patients and their expectations had changed. So for a healthcare home team, you know, we took a step back. We had 10 in the program at the time, and we had 10 out of the program, and we were really concerned that we were creating inequities in our own program. And we were leaving pockets of our communities, particularly our high needs communities, behind. And we decided that we were going all in as a healthcare home team and supporting all our practices and taking them on the journey. And they really stepped up to the mark. So it's been quite difficult, as you know, as we changed in different levels, that we have to go back around and review those systems and that workflow, and that will continue on for months and months. But they're up for the challenge. They're up for us to come back in. There's always going to be teething issues, as our healthcare home practices know. You don't get it right the first time. So you have to go back around and change things up and make sure it works for both the patients and the providers. So yeah, for our practices not in the healthcare home program, they challenge me and say we're not non-healthcare home practice. We do a lot of the components already. It's just that we're not in the program and we don't get the funding. So there was definitely a shift in their mindset, and we wanted to build on that momentum and then embed the changes and make sure that they don't revert back to the old, which is easy. So we proposed to the DHB, put a proposal together a couple of weeks ago to fast track these practices not in the program and get them into it fairly quickly, fairly swiftly by July. And to do that, we realised we were going to have to change our quite strict and structured change management program that we take them on. So we proposed to remove the, in talking with them, there was a lot of barriers. The huge and comprehensive expression of interest document that they have to fill in. I think it's about 30-page long. It's a procurement process that sits with the DHB. So we proposed to remove that. We also, alongside that, we had readiness assessment visits, with the whole team, and then with management teams. So we proposed to remove that. We knew they were willing and ready to go. We've done scoping of the gap for a number of them, and they were really quite mature in some of the requirements of the model. And, in terms of, when you do a change management program, it's about practices finding their why. And for many of these practices, they'd actually found their own why. For years, we'd been taking our healthcare home practices, 2 or 3 years, trying to get them to find the why. And for these practices, in the 24 to 48 hours notice they found that fairly quickly. So the other important factor that we're looking at, these implementation plans that we put together for practices, we're really going to change it and look at a more change management plan, something quite succinct and, with strict timeframes and things like that, so people can move fairly quickly and keep making change as we go through it. As a PHO team, that meant that we could all get on board and all deliver healthcare homes. So we kind of stopped working in our program silos. We could all focus on supporting practices through proactive care. And now we're, in discussions with the DHB where the integration neighbourhood models can be an all-inclusive model. Whereas we were looking just at pockets of our healthcare home practices, we can start to roll that out across our communities. And we also don't want to lose sight of equity in all of this. So it's really exciting that our practices that are coming on are ones that have, a high percentage of priority patients, and that might mean a slightly different journey for them, but, we're willing to get them on board. The model of care enhancement work that the National Collaborative working on at the moment, we can see that really fitting quite nicely as we mature through the model. That's me.
Great, thanks, Jess. And it's important, and it's good that you've highlighted that not everyone is healthcare home. About 1 in 4 New Zealanders are covered by healthcare home currently. So this is a journey that we're all on, and I think the challenge is how do we democratise the information and the experience of healthcare homes so that it's spread right through New Zealand, so that every New Zealander can experience the benefits of the learnings that have come from the Healthcare Home Collaborative. So fantastic. That's some great presentations that we've had there, and hopefully that's answered some questions. It's also raised a few, so we might get into the question and answers. And so I'll just take a selection of those, and anyone can field them. But first one to Nicky, someone's asking about failure rate with the virtual platforms and Doxy.me. Do you know if there's other platforms out there that people have been using other than Doxy.me? Because I know it doesn't work that well with iPhones. You're on mute, Nicky. Nicky, can you unmute? Oh yeah.
Sorry, we're using Manage My Health as the platform, which I understand Doxy.me is the underlying platform anyway. It's all. I'm not sure I want to advertise any others. Those are the only 2 that I know that are working. I understand Indices got a video platform as well. But to be fair, in our experience, it's not just the platform that is the problem. It tends to be people's ability, a bit like Zoom. It's like, we're all experts now, but prior to COVID, we were like, oh, you're on mute and, I can't get video, and sometimes you can get video but no audio, and exactly the same thing happens. So the clinician then becomes the technical expert in trying to guide. It's often the patients and guide them into saying, well, can you click on your setting and look at where your video, all that sort of stuff. So I think, that said, we've had I think the Wi-Fi is a big deal. We're in a rural situation and Wi-Fi is not always very good. The consultation's only as good as your Wi-Fi is. So I can't comment on the quality of the platforms, and I'm not sure about others that are around, but we're using Manage My Health. I've used Doxy.me before pretty successfully, but the problems tend to be associated with, you know, user issues and Wi-Fi and a bunch of other stuff. So you just gotta, I think it's just practice really, to be honest. Yeah.
Great, thank you. I don't know if anyone else has experience with other platforms. If not, we'll move on to a question for Lance. How do we ensure that virtual health doesn't drive inequity?
I think you have to have a concurrent strategy. So I think this gives us a good opportunity to reflect on our current face-to-face general practice model and how we can make it even better, but how we link virtual care. So some of the things I spoke about, health literacy for our families, I think we should be doing that in general practice today anyway, and getting our key messages right, and informing our whānau how to access various medical tools. So there's a huge amount we can do. So I don't see virtual health being the only healthcare model. I think it being another component of our model. But because it's a starting platform, we can start it from the best position, which is let's put equity first, rather than us always having an after the fact conversation about equity. So we can build it into the logic, and then potentially we could use some of that logic model into our face-to-face GP model of care.
Great, thanks, Lance. And Mabli, you also mentioned the thing about free data as well. That might help address that problem as well. A question for you, Mabli, was about the triage tool that you mentioned. Someone was asking a little bit about that, what the name of it was.
It's called, if memory serves me well, eConsult. So if you Google that, you can look at it. There is, I've seen a demo link being sent around, so I don't know whether the collab will be happy to share that. It's one tool. I think there are other tools similar to that elsewhere, but it's the tool I think that N4 is looking at. So yeah, have a look. It's got a nice symptom checker on it. The patient can go through and click on various body parts, etc., and answer certain questions, and then that all goes through to the GP, and they can take a view about whether they need to call the patient or they can manage them totally virtually, and it can end up in a script being issued as well with not even a conversation with the patient. So it is really for patients who need to be seen on that day. It's a replacement to or a sort of complement to telephone triage, but it's called I think the product they're looking at is called eConsult. So you could just Google it.
Great, thanks, Mabli. Next question is about e-commerce and how do people deal with bad debt, and do they have any tricks there? I was interested in the survey that you sent through, Nicky, about if collecting payment on the day, if you don't text them, that you get about a 30% return, and I think it goes up to 60-something% if you text them. So yeah. Good there. Do you have any other tricks, or does anyone else have any other good advice on e-commerce and keeping cash flow going, because we are very cash flow sensitive?
Yeah, I mean, just the things that have really worked for us, and it's well known in the business world, is the earlier you collect the money, the more likely you're going to get it. So I think on the day texting is really important, and giving them an easy way to pay. Here's our account number, please put it in. And then, so with that, we've been getting about 70% on the day payment. The other thing we found really helpful just recently is I did a bit of a panic buy in alert, you know, as we were coming into alert 4 on mobile EFTPOS machines. I'm not sure why, it was just, you know, webcam machines, but they've been quite helpful because the we have a call centre, and they can use the mobile EFTPOS machine in the call centre. So if people ring up and go, oh, how can I pay? They just pass the EFTPOS machine around and can pay over the phone. I mean, the payment platforms are good. The big issue I've found, and the reason we haven't adopted them yet, is because the transaction fees are quite high, but the bigger problem for us is that we have a whole system in our practice around on-the-day reconciliation, and most of the payment platforms hold the funds for several days before they get passed back to the practice. And yeah, I think in time they'll be great, but that's one of the main reasons that we haven't adopted a sort of an online Stripe or all those other ones, because it just would mess too much with our current systems around reconciliation. Yeah, so I don't know, I think, you know, account numbers, pop it in the bank is pretty good.
Great, thanks for that. Lance, Sorry, Lance, can't hear you.
There's an opportunity for us to reach out to Work and Income. So currently there's rules that if some whānau can't afford to pay a face-to-face consultation, Work and Income will actually pay part of that consultation now. So what we could be doing is reaching out to Work and Income and saying, how do we apply those same rules to a virtual consultation? And then if we really were switched on, we could preempt that conversation to say, well, actually, here's our database who's been using Work and Income on face-to-face, and could we get pre-approval for virtual consultation payments directly through WINS?
Yeah, good point, Lance. Someone we do need to be working with in partnership. Good. Next one I might direct to Mabli, but everyone can jump in. How do we promote value of virtual care in the post-COVID environment to our patients and our doctors, for that matter?
I think there is something around the experience of our 2VLCA practices, which is that group function. And I think both patients and clinicians have reported back that that's been a real value add. So being able to factor in, the interpreter or, the family member who doesn't live locally, and even if it was a regular in-person consultation, wouldn't have been able to get there to be there with the family member. So having two pairs of ears in the consultation, I think there's some evidence that patients remember 10%, Jeff, of what a GP tells them in the consultation room. So maybe there's a 20% chance that more is heard if you've got two pairs of ears. So I think that's a real value add. And I think the clinicians and the patients, the practices where they've been doing that would definitely never go back, I think. I think it's the convenience factor. So people like me, I would love not to go to the GP and have a virtual consult because I'm time poor. So again, that kind of time poor. I think value add around people who have mobility issues or who have travel issues or live in rural areas, being able to have a virtual consult saves time, petrol, finding someone to look after the kids. All of that, I think, is value add. It's about access and convenience, really. But I do think that the penny really dropped, I think, on that group function, those practices and those patients.
Thanks, Mabli.
Jeff, I think we need to keep offering it as an option because it will take time for this to embed. And I think about the grocery shops that put those self check-ins where you could do it yourself. The first couple of times you kind of rolled your eyes and thought, oh, why am I doing this? And then now it's just part of your day-to-day, like who would go stand in the checkout and wait for your groceries to be scanned and things like that, when you can do it yourself probably much quicker. So I think it just will take time and embed, and people will get used to it, and that will just be the new way.
Yeah, good point. And I think it's really, post-COVID, we're really saying to patients, what we've done is we've increased the number of ways that you can interact with your doctor, not decreased. And face-to-face is still on the menu, but it's one of the service offerings. And as you say, Mabli, there are a number of currencies in which we can measure that value that we deliver to patients. That may be in carbon credits, time saved, convenience, all sorts of ways that we can measure and deliver that value to patients. And let them choose. We shouldn't be scared to let them choose. This is about patient-centered care. It does need to work equally, though, well for patients as well as doctors. For these to be adapted, but we want to make sure we don't slip backwards in this. Look, another question is, what are we going to do with our waiting rooms? We're not going to have patients who are going to want to come into a busy waiting room, sit there eating a 10-year-old National Geographic covered in COVID, or share toys in a shared playground anymore. Are we going to continue to keep people waiting in their cars and text them or phone them when they come in? I don't know how people are going to solve this one. We'll do the rounds. Mabli, do you want to make a comment first?
I don't know. I've been round. I went to a practice this morning, actually, for my first in-person visit for a while, and we were talking about what they were going to do, because their physio provider was going to come back and their counsellor was also going to come back. So we talked about scheduling, and I think that blend between telephone and virtual, so just making sure that templates are scheduled carefully, so not everybody is doing face-to-face at the same time. So it might be that the telephone and the video or the virtual consults are offered while one GP does those and another GP does the in-person consultations. I think there's something about taking lots of chairs out the waiting room because that stops people. And then the rooming idea that which never really landed locally, but the healthcare home idea of being roomed, so somebody picking you up in the waiting area and putting you in a room. If you've got enough rooms, of course, there's logistics there. So I think it is. I mean, I'll be interested to hear what others think, but I think it is a challenge for practices. They've been used to patients sitting and waiting physically in one space, and I think those days are certainly over for a while.
Thanks, Mabli. Nicky, any thoughts from you?
Yeah, just we have been thinking endlessly about this, and our waiting area also has people come in to our waiting area in shared reception space to access the pharmacy and phlebotomy and radiology, and we literally have people moving from service to service, so it's extremely difficult to manage the flow, and particularly with pharmacy. Actually, there's a lot of volumes are massive, so we're screening as much as possible and sending all the respiratory symptom patients to a sheltered area where they will be assessed and swabbed and brought in for treatment if they need to, and it's in a isolated area where the clinicians will use PPE gear. So that's our plan. But I think the biggest risk is people that may have been booked ahead of time for routine things, but then have a runny nose or whatever on the day, and how do we capture those people, the people that bring a lot of people with them for consultations who we don't know about, all that sort of stuff. So those are the ones that we're struggling with, identifying how we stop them at the front door and make sure they don't come and spread COVID all over the National Geographic. That said, in our community, it's a non-COVID prevalent environment, and the approach will change depending on that. So we're going to review it frequently, and we will be adaptive as we have been up until now. Yeah.
Good, thanks, Nicky. Jess, any thoughts?
Yeah, I think practices are doing a lot of thinking in the space, and they will come up with their own option, what works, because as we know, every facility is different. But we've talked about cough and cold clinics at the end of a day, so it's easy clean down rather than either at the start or mixing it up. And like Mabli said, the scheduling, so phone broken up to an in-person consult, so you don't have lots of people in the waiting room at one time. So I think we'll get there with options. It's still early days in alert level 2, but yeah, practices will come up with their solutions.
Yeah, agree. Lance, any thoughts?
Yeah, I think if you look to what's happened in our cafe industry in the last few weeks, the technology that they've advanced in terms of you go into a queue now, and then it texts you 5 minutes before your food's ready. So I think if we think about things, start practically and say, how do we make technology our friend? So if there's a booked appointment, I would love to get a text to say, please don't come into the appointment until 1 minute before the doctor's ready for you. But if you had sequential text saying, hey, the doctor is running half an hour behind or running on schedule, your booked appointment is here. It'll change how we rock in, when we park, when we enter the business. So I think some of the technology that's been developed across retail in terms of social distancing, not having one in, one out of dairies, that seemed to have worked quite well. I think if we apply some of that logic, people sitting in a waiting room for 2 hours must be so frustrating. If you had a text saying I'm an hour behind, then that would be so much better. You could pick up the kids earlier or drop them off earlier. So I think technology will be our friend in this solution. Yeah,
and I think as you say, we can learn from other industries and what some of their solutions are coming up. So that is a space that we should keep an eye on. There's another question about differential fees for phone consultations, virtual consultations, or in-person consultations. Does anyone have differential fees, or do they charge exactly the same? Certainly we charge exactly the same, or have been over the last 7 weeks.
Yep, ours are different on the basis that the virtual consults tend to be a lot quicker. So I think I would determine that on the basis of time. If they're a lot quicker in your practice, then it's probably reasonable to differentiate. So our phone and video consults are the same, so they tend to be about 15 minutes at the moment. They'll probably get quicker once we get better at them. And phone consults tend to be about 10 minutes, so we charge 75% of our face-to-face consult rate. Yeah, and that works pretty well for us, for the business and for patients.
Jess, what's happening in Te Awakairangi?
Yeah, so again, each practice is different, but in terms of triage, that for us, if they're a healthcare home practice, it is free to the patient, but same rate for a phone consult and video consult. So I think it gets hard when a triage call merges into a phone consult, and that's hard to differentiate, and that's happening a lot. So we're thinking about that at the moment.
So is the thing that differentiates it whether you resolve it or not on the phone? Or time, or combination of both?
Yeah, I think it is guided by the clinician,
yeah.
And the conversation and what's happened and what's been delivered in that time. So.
Any other comments, Mabli or Lance? No, okay.
But I think the key is the value add proposition, so that there's an expectation prior to my virtual consultation that this is going to cost me the same amount as a face-to-face, because the time and effort and resourcing is the same, the engagement time is the same, but have a predetermined message to whānau, so it's not a shock to the system, and pointing out that, hey, you've saved on a petrol, you've saved on sitting in a waiting room for half an hour, and then someone might go, well, that's actually totally worth the same amount of value. So I think if you have those as key messages before the consultation, it kind of covers the awkward, oops, I thought this was just the phone consultation.
Yeah, agree. And often the phone consultation takes just as long, because by the time you safety net and make sure you're safe, takes about the same amount of time. So as you say, it's about how you deliver value in a number of currencies and not just in person. Good. We might start wrapping up, and there's one more question about Tend, which people have probably been hearing about. This is another virtual platform that is being promoted and developed. Is that something that we should be worried about, or is it something we should be combating, or is it something we should be embracing? For those who don't know what Tend is, it's kind of Babylon NZ, if you like, to a certain extent, and we are open to competition in this sense. So we might just go around the panel as a wrap up and see what their thoughts are. We'll go, Lance, you can go first.
Yeah, so I think any form of change to the health system is competition for us, but competition is healthy. So if we stay and do nothing, then shame on us for allowing other organisations to do what we could have developed ourselves. So my answer to Tend is, why don't we just do what Tend intends to do themselves, but as a general practice network that we already have an enrolled patient base, we already have a virtual consultation framework, we already have a workforce. So if you thought the healthcare system was going to stay the same, then shame on you if Tend takes your organisation out. But if you adapt and you come up with more positive opportunities, solutions for our communities, then we're going to be ahead of the game anyway.
Great answer, thanks, Lance. Anyone else want to comment on that? Mabli?
I agree with Lance. I think it's an opportunity, and I think that it wouldn't take much to what we want to offer is continuity. Oh, the lights just gone out. What we want to offer is continuity, but also possibly what Tend offer is extended access, and it wouldn't take much to turn some of our after-hours services into a virtual offering for patients. So I don't think it would take much for most networks to put an offering up that complements general practice rather than competes with it. I think we're halfway there already with what's gone on in the last 6 weeks.
Great, thanks, Mabli. Nicky, did you want to make a comment?
No, I concur.
Okay. Jess, anything to add?
Yeah, I agree as well. And I think, with extended hours in the healthcare home program, that's an opportunity to provide virtual care in that space. So again, providing the extra access and yeah.
I agree. And look, I totally agree with all the comments so far. Babylon was a disruptor, and we've used that to start getting into this space, and COVID was the kick in the pants that we needed to kick this down the road, and we are further down the road from 7 weeks ago, so that's good. So look, we might wrap up there now. It's been a great session, and I want to thank all of the panel members for your input this evening. It's been very enlightening. I also want to thank Amja and Scott from the Healthcare Home Collaborative for all the help that they've done in putting this together tonight. And just a reminder, if you do need more support, you will have most of the DHBs who are engaged in healthcare home do have healthcare home leads who can support you on this. And if you're not sure who to call, you can get in touch with Amjad at the Healthcare Home Collaborative. So they are the leads who are spread around the country. A fantastic group of people who are full of energy and fantastic to work with. So we're going to finish with a karakia from Lance, but before we do that, just want to mention that a link to this will be up on the Healthcare Home website. So if you want to watch this, or if you know people who have missed out and haven't been able to register for tonight, the link is on the Healthcare Home Collaborative website. I'm just reminded, looking at the Healthcare Home Collaborative logo there, those concentric circles, blue, it reminds me of a program back in the 60s, which no one will remember unless you're as old as me, called Time Tunnel. And it was about people going from now into the future. And what COVID has done is it's opened up a time portal for us. It's unlocked the system. And what we need to do is take all of this technology, changes in models of care that we have, stuff it through that time portal into the future and make sure it closes up behind us so we don't go back to what we were doing before, and ensure we lock in the changes. So as I say, we're now in the rebuild, reconfigure and re-engineer phase. Let's go forward and imagine what the future can look like and get on with the mahi that needs to be done now. So with that, again, thank you to the panelists. Thank you for your attendance, everyone online tonight. And I'll hand over to Lance to say karakia to close this session.
Well, kia ora, Jeff, and kia ora, team, for presenting. I'll just close us. Kia tau, kia tātou katoa, te atawhao tō tātou I karaiti, me tō aroha o te atua, me te whiwhi nā tahitanga ki te wairua tapu, ake ake, āmene.
Kia ora, Lance. Great.